Thank you, Mr. Chairman. And again, I want to thank the organizers for inviting me, particularly Dr. Shalkot for getting me here and Dr. Banshi to make it possible. This is my third trip to India, and I'm really very excited coming here, and I hope it's not going to be the last. So my topic is quite a big topic, but I'm going to concentrate on some aspects of diabetes and cardiovascular disease. We know for certain that people with diabetes have a very high cardiovascular risk, and there's a lot of evidence to prove this. But there are still some questions, and I'm going to address a few of them. I'm going to address the ones that I'm listing here, but as I said, there are many others. The first one is about whether diabetes is really a cardiovascular disease equivalent. Should we consider every patient with diabetes as having cardiovascular disease? And you all know the study done in Finland and directed by Professor Aschner, where they found that there was no difference in the risk of both MI and death between people with diabetes and without any evidence of cardiovascular disease, and those people who were non-diabetics but did have cardiovascular disease. And this was a cohort study which lasted for more than 7 years, and then there was another one which lasted for around 15 years, and they both showed that there was, as I mentioned before, no difference. Same was found in a study in the US, although with a lower number of patients of events. And when you look at the other studies, in general, in this meta-analysis, there wasn't, in fact, an equal rate of cardiovascular disease. There was a lower rate in people with diabetes compared with people without diabetes and cardiovascular disease, and it was almost 50% less. If you look at the difference between these studies and the other ones which didn't show this difference, basically, probably it has to do with the year in which these cohorts were studied. And this is a meta-regression analysis I did of many epidemiological and intervention studies looking at the control group. And what you can see here is a graph depicting in the x-axis the year at which the patients were probably diagnosed according to the duration of the diabetes in the patients included in these studies. And in the y-axis, you can see the annual mortality rate. And it seems that the mortality is basically related to how far away the patients were diagnosed, which means what kind of treatment they were getting at that time. So the recent studies, probably having a more comprehensive treatment, and particularly in the lipid area, they have less mortality. So probably this is the reason why the recent cohorts are really not equivalent in people with diabetes to people without diabetes and cardiovascular disease. Now, the other question is, if they are not equivalent, do we have to score them? Do we have to try to find out what's the risk? And the recent proposal of the American Heart Association to give statins at a high or low dose depending on the score seems to be in that direction. Here is the algorithm they propose, and at the end you can see that people with diabetes, if they have a high score above 7.5%, they should be given a high dose statin. Otherwise, a low dose or moderate dose statin. And they propose to use this risk, the atherosclerotic cardiovascular disease risk score, which includes diabetes. But there has been a lot of critique on this proposal because this score doesn't really apply. It hasn't been validated in other populations, as for example in the Indian subcontinent. And in fact, what this author says is that it overestimates the number of people who should receive high-dose statin. What's the difference between this risk score and others, like, for example, the UK PDS, which has been the classical one we've been using since Framingham has taken away diabetes because of this, the fact that it's a cardiovascular disease equivalent. If you look at the two scores, they both are used in people with diabetes. They both have a similar time frame, but the outcomes are different. In the case of the pooled cohort equation, the outcome is a composite of both stroke, coronary heart disease, and death from both of them. While in the UK PDS, they are considered separately. The high risk for coronary heart disease is considered as above 20% in the UK PDS and above 7.5% in the score equation. And based on the variables that they use, you can see that the pooled cohort includes treatment of hypertension, but on the other hand, the UK PDS includes variables which are very important, such as HbA1c and duration of diabetes, etc. But basically, the problem in comparing these scores is that they address a different risk, and the proposal of the UK PDS is that you should lower the high risk to 15% if you want to compare it with a pooled cohort where it's a composite of cardiac outcomes. Doing this, we tested it in more than 600 patients in our diabetes center. You can see there the characteristics. And we found that with the UK PDS risk engine, around 48% of the patients were high risk. These were patients referred with usually bad control. And with the ASCVD score, 66%, that was higher. But the concordance was very poor between the two of them. If you look at those who concurred and those who didn't, the people who didn't were more females and had higher blood pressure. And if you look at those who scored high only in the pooled equation, they usually were older and had, as I mentioned before, higher blood pressure. And those who scored higher only in the UK PDS were those who had higher HbA1c. So probably they are looking at different characteristics of the patients, and therefore they cannot be really used in the same patients at the same time. And probably the best approach for the time being is to consider that every patient with type 2 diabetes, as the European Society considers, should have a statin if they have an LDL above 70. And if you cannot lower it to 70, at least you should lower by 50%. And for the time being, scores are better left for validation. What about the impact of blood glucose control? We know that the multifactorial approach is the best, and we would like to know what's the role of controlling blood glucose in a multifactorial approach. And the steno showed us that it's not as important as statins, but still it's important, not as was mentioned by my previous speaker, that it has really not much impact. But the problem was that they didn't reach the goal in the steno trial. Only around 15% of the patients were able to get to an HbA1c of less than 6.5. But what happens if you try to go lower? And this is a meta-analysis, the most recent one, where they analyzed intensive strategies to go lower. There you can see the Accord, the Advance, and the VADT, and also strategies where they used other approaches. And this is all-cause mortality. And you can see that only the Accord had a higher risk and the Steno had a lower risk. The rest were neutral regarding all-cause mortality with intensive blood glucose control. Basically, the meta-analysis showed that there was a benefit on myocardial infarction and lower limb amputation, and as expected, also in microvascular complications. That is well known that the lower the blood glucose, the lower the risk of microvascular complications. But this has a cost, and the cost is that you have higher hypoglycemia with intensive blood glucose control, and this has been shown in all the trials and in meta-analysis. What's the risk of doing intensive blood glucose control? Is it the intensive control or is it the drugs we use? And this is another meta-analysis where they looked at this. Actually, this was a meta-analysis where the main outcome was heart failure, but they also analyzed major cardiovascular events. And you can see there that including those intensive treatment trials, and also the ones that use different glucose-lowering drugs, you can see that the general effect was a benefit in favor of the blood glucose-lowering strategies. So in general, it does pay to lower blood glucose in terms of less major events. Analyzing each event separately, you can see that the main effect, as with the other meta-analysis I showed, was with myocardial infarction. But then there's the other side of the coin is that there was a higher rate of heart failure. By the way, the meta-regression analysis showed that there was a decrease for each 0.1% difference in HbA1c, a decrease of 3.5% in the composite cardiovascular endpoint. So what about heart failure then? Again, looking at heart failure, there seems to be a higher rate of heart failure when you give drugs, glucose-lowering drugs or intensive strategies. But if you look at which of these strategies actually are related to heart failure, it's not the intensive control. Here you can see that it's neutral. It seems to be related to the drugs. We already know about the PPAR agonists. They are classically related to increased heart failure. But it seems that the DP4 are still questioned, basically because of the SABRE-TIMI study, which we already know showed higher hospitalization for heart failure. We will probably know more about it with the TICOS, which is going to be reported at ADA meeting. So then we will be able to balance what is really happening with heart failure. Interestingly, in this meta-analysis, heart failure was related to weight. And for every 1 kilo of weight gain, there was a 7.1% relative increase of heart failure. So it may have to do with a confounding factor and not exactly with a drug. And what about the sulfonylureas? This is a very complex graph of the effect on all-cause mortality, direct comparisons between different sulfonylureas and metformin. But basically, if you compare the effect on all-cause mortality of glibenclamide with other SUs, and particularly with tolbutamide and chlorpropamide, well, there is a higher rate of mortality rate with tolbutamide, for example, compared with glipizide and with glibenclamide. It's significant. But then if you get rid of the old drugs such as chlorpropamide and tolbutamide and you analyze the new drugs such as glycoside and glipizide, it does seem that glycoside particularly causes less mortality than glibenclamide. Glipizide as well has higher mortality than gliclazide. With glimepiride, there's a slightly higher mortality with glimepiride when you compare it with gliclazide. So the SUs are not all the same. And in fact, you can see here that gliclazide seems to be different in terms of lower mortality, and on the other hand, glibenclamide, which is the reference, seems to cause higher mortality, and this should be considered when we choose SUs. Metformin, in general, has lower mortality when you compare it with any of the other SUs. But then, in this meta-analysis, the authors differentiated between cohort studies and randomized clinical trials. And in fact, it seems that SUs rate higher in mortality risk when you look at cohort studies, but it doesn't seem to be the same when you go to randomized clinical trials, where apparently the risk is the same. So this question has to be solved, and the ideal would be to have a long-term clinical trial with SUs, but probably that's not going to happen because it needs a lot of sponsor, and probably it would have to be done by the academy and not by the pharmaceutical companies. They would not do something like that. When you look at SUs and against controls with the other drugs, in fact, it seems that where there is a difference is between SUs and DPP-4 inhibitors, and where DPP-4 inhibitors have less risk, in this case of MACE, that means composite outcome, compared with SUs. And there is a trial going on, the Carolina, which may answer this, because it's going to compare a DPP-4, or it's comparing a DPP-4 with an SU. So, and actually it's glimepiride, so we will know if there is a difference in cardiovascular mortality. So I think I hope I've tried to show you some aspects of diabetes and cardiovascular mortality. Basically, that not all the patients with diabetes have a risk equivalent to having coronary heart disease, but probably it's safer to consider that they should nevertheless receive a statin if their LDL is above 70, and maybe the risk scores are still in need of validation to be able to, so that we can use them in clinical practice. For the time being, probably the UKPDS is the best. I think I've tried to show you that cardiovascular risk can be reduced with intensive control, and actually, particularly myocardial infarction is less when you give intensive control, but then hypoglycemia is the problem, and because of that, probably you have to use appropriate drugs to lower blood glucose. And some drugs may actually increase the risk, and this is something that has to be looked into, and particularly in the case of SUs, they should be used carefully. The new drugs, particularly the DPP-4 inhibitors, still have some question related to heart failure, and certainly the glitazones do have a higher rate of heart failure. I didn't mention the SGLT2 inhibitors because they haven't been analyzed, meta-analyzed, compared with other drugs yet, but probably the evidence will come by, and the same for GLP-1 agonists. And with that, I want to finish by inviting you all to the World Diabetes Prevention Congress in Cartagena, in my country, in October this year. And it's not that long. I came here, so you can go there. And finally, thank you very much.